Can it be prevented? Well, I think if you do a thorough history, try to distinguish pain of vascular origin as opposed to musculoskeletal origin. Do a good physical exam. Try to see if you can identify a manipulable lesion. In the absence of that, that may raise the specter of doubt that there's something else going on. And discuss those risks with the patient. And I think then, yeah, some of the cases can be prevented. Listen, for those with stroke symptoms, like weakness, numbness, slurred speech, drooping in the face, blurred vision, loss of balance, we can screen those at the front desk. That's not the problem. That's not the issue. Right? So what should that history look like? Like I said in the beginning, I think it's important to distinguish pain of vascular origin as opposed to musculoskeletal origin. Pain of vascular origin is constant stabbing, piercing, throbbing, and the pain radiates into the occipital or temporal region. Mind you, these look a lot like the patients we're treating every day with musculoskeletal pain. But I think one of the most distinguishing features, and you probably know this, right, is that what we know from the patients who had a dissection in the past, they complain about the worst headache they ever experienced. So if a patient says this to you, alarm bells should start to ring. And you should raise the specter of doubt, hey, that there may be something else going on. It's not a mechanical lesion, but a dissection in situ. Pain of musculoskeletal origin is aching, sore, heavy, dull in character, and the pain radiates into orbital, periorbital, or frontal region. I think one of the most important things is the risk factors for cervical artery dissection, those with the connective tissue diseases. Ehlers-Danlos, Marfan, scleroderma, Sjogren's, fibromuscular dysplasia, lupus. But I think it's also important to screen for those who are on the spectrum of hypermobility, those who could overstretch their knees, those who could bend completely forward, those who could bend their thumb backwards, overstretch their arm. And it's easy to understand why. Right? These diseases, the connective tissue diseases, result in a weakness or fragility of the vessel wall, making it more likely and more prone to tear. Questionable whether the vascular risk factors like hypertension, hypercholesterolemia, hyperlipidemia are important risk factors for us. I dare say not, and I think it's important to understand the distinction in the mechanism between non-dissecting stroke and cervical artery dissection. Non-dissecting stroke is caused by atherosclerosis, hardening of the arteries. Cervical artery dissection is caused by a tear of the intima and media. Given the fact that these mechanisms are different, you would expect that the risk factors are also very different, and they are. Non-dissecting stroke is seen in those older than 45, on average, with vascular risk factors, hypertension, hypercholesterolemia, hyperlipidemia. Those who are risk for cervical artery dissection are those less than 45, under 45, with connective tissue diseases, like Ehlers-Danlos, Marfan, fibromuscular dysplasia, lupus, and I dare say those who are on the spectrum of hypermobility. So what should that physical exam look like? Well, neck pain of musculoskeletal origin can be reproduced or relieved by movement, and can be accompanied by reduced rotational and/or lateral flexion resulting in pain. You can imagine pain of vascular origin can be reproduced or relieved by movement and won't be accompanied by rotational or lateral flexion. So in the absence of a manipulable lesion that should raise the specter of doubt, potentially there's something else going on. I think a good physical exam should also include a cranial nerve exam. I won't go into that. There's lots of examples on YouTube videos, and refer you to those. What about vertebral-based or insufficiency tests? Right? Should we use those to screen our patients? There's a suggestion that maybe these are valuable screening tools, or valuable screening tests. Now, what we know from recent systematic review, okay, is that these cannot be recommended, should be banned, because a negative test can be wrongly interpreted as safe to manipulate. It could lull the chiropractor or manual therapist into a false sense of security. And in short, we know that these tests have a low sensitivity and therefore not valuable as a screening tool, so don't do them. You can do them, but they have very little value. What about informed consent? What's the role of informed consent in this whole story? Well, contrary to what some people might believe, believe. It's not there to protect us. It's there to protect the patient. And more importantly, it allows us to have that conversation. What conversation is that? Well, this is the informed consent from Netherlands endorsement of the Netherlands Chiropractic Association. We name that, which we actually don't want to name, right? A dead stroke. It's taken literally from uninformed consent. In extremely rare instances, a person may have a dissection of a blood vessel. And in most severe form, this can result in a stroke with a number of outcomes, including permanent death. Now, mind you, I've been giving this consequently to patients for the last 3 or 4 years. It's never been an issue. Patients never said to me, please don't adjust my neck. And in the rare instance, when they did, if they ever did, we talk about it. Having said all that, Katie talked about the elephant in the room. I also want to talk about the elephant in the room. Does cervical spinal manipulative therapy cause cervical hernia dissection? Well, to understand that, you have to understand something about study design. Case control studies and study design is the gold standard when investigating rare disease. So what does that look like? Begin first with the cases, those who have the outcome of interest, cervical hernia dissection, and you go backwards. Try to assess those who try to assess exposure to the variable of interest, in this case, cervical spinal manipulative therapy. And essentially do that for a suitable control. What a suitable control is something we can talk about. If you find exposure is equal among the cases of controls, there's no increased risk. It's just that simple. If, however, you find exposure is greater among the cases and the controls, then you have a bit of a problem and a bit of explaining to do. Now, mind you, there's some limitations with design, there's limitations in all study designs, even randomized controlled trials. Most importantly, it's retrospective, but it makes clear how difficult this is to study. It's not possible to examine this prospectively, given the incidence approximately 1 per 100,000. It means we'd have to include close to 1 million patients. We'd have to include 1 million patients just on average to get 10 cases, and then even then, we don't have sufficient statistical power. Most important forms of bias, and of course, the epidemiologist has recorded, of course, we're going to talk about bias, information bias, selection bias, and confounding. Those are the most important forms of bias in observational studies. Information bias is a problem when there's systematic difference in the way exposure to spinal manipulative therapy is assessed. Now, a suggestion when patients are admitted to a hospital with a dissection, they're more likely to be asked to have been to a chiropractor days prior to the stroke, and therefore likely to remember that years later, more so than a control group. On the other hand, we can use insurance claims data, but as soon as a certain visit equivalent to what the chiropractor might have done in clinical practice. So billing for an upper cervical visit doesn't mean the chiropractor necessarily adjusted the upper cervical spine. Maybe did something else. Maybe did mobilization or soft tissue massage or something like that. So these are some of the problems with observational data studies. The other form of bias is selection bias. Selection bias is a problem when there's systematic differences between the cases of control.